Team, whether you're in person or whether you're online, thank you very much for joining us today. It is our distinct pleasure to welcome Dr. Michelle Kittleson to do today's lecture for Heart Failure Grand Rounds. I know most of you are very familiar with the work, but just in terms of introduction, Dr. Kittleson is a professor of medicine at Cedars-Sinai. She's the director of education at their Heart Failure Transplantation and director of heart failure research at the Schmidt Heart Failure Institute at Cedars. She's a deputy editor at the JHLT, one of our seminal journals, and she's been on the writing committees for the current 2022 heart failure guidelines. And she's also chaired the AHA Scientific Statement Committee for cardiac amyloidosis. She's also going to be also working on the 2023 ACC Multidisciplinary Care for the Patient with Amyloidosis document. She is extensively published in the New England Journal, Annals of Internal Medicine, JAMA Cardiology. For those of you who follow her on Twitter, hashtag are famous and often quoted. We are tremendously honored to have her talk to us today on an approach to antibodies in heart transplantation. Dr. Kittleson, thank you for your time and for sharing your expertise.
Thank you so much. I am delighted to be here, and thank you for that very warm introduction, probably warmer than if I'd been personally in person in Cleveland. So, because you know us Los Angelinos like our 70-degree weather. So I'm so excited to talk about approach to antibodies in heart transplantation. I will discuss the off-label and or investigational use of everolimus, bortezomib, eculizumab, and tocilizumab, and I have no relationships to disclose. And because everything is more interesting when we talk about a patient, let's begin with a case. A 35-year-old woman, 4 months post-transplant. She's on standard triple drug immunosuppression with prednisone, tacrolimus, and MMF. She presents to an outside hospital with nausea, vomiting, abdominal pain, and fatigue. She's prescribed ciprofloxacin for gastroenteritis and sent home, and returns to the ED the next day with worsening symptoms. What do you advise the ED staff when they call? Now, I imagine that for those of you in Cleveland, it's very similar to us in Los Angeles, where many of your patients that you transplant don't live right next to your hospital, and you're often fielding calls, triaging from outside emergency departments. So let's say your options would be colonoscopy, pan culture and begin IV antibiotics, check an echocardiogram, or discharge the patient on pantoprazole. So I would say a good rule of thumb in medicine is that whenever a patient presents multiple times or with a recurrent symptom, it deserves closer attention on the next go around. And the second rule is that if you are within the first year of transplant, any symptom is rejection until proven otherwise. So you advise an echocardiogram, and it demonstrates an EF of 20%, or symptoms are likely coming from hepatic congestion. She's transferred to your hospital where her heart rate's 130, blood pressure 80/60, multiple runs of NSVT. Her JBP is elevated. She's an S3 gallop, cool extremities. Dopamine is started, biopsies performed, and a PA catheter shows the very picture of cardiogenic shock with an RA of 20, PA 45/30, wedge 30, and an index of 1.3. So what happens next? How do you manage the patient? Well, you could do an emergent coronary angiogram, consider a balloon pump if she deteriorates, initiate anti-rejection therapy, administer IV diuretic, start IV heparin. I would argue that an angiogram is probably overkill at this point. She's only 4 months out from transplant, and while you can get a vasculitic picture with accelerated vasculopathy in the context of acute rejection, that's probably lower on your differential, but I'd argue that any one of these other options, B, C, D, or E, are acceptable. And when we think about the treatment of rejection, I like to divide it into what the patient looks like and what the biopsy looks like. So for those patients who are asymptomatic, if they have cellular rejection, you may just target higher levels of the calcineurin inhibitor, give them an oral steroid bolus and taper, and switch their MMF to a proliferation signal inhibitor, or PSI. And if they have antibody-mediated rejection, they'll probably bot themselves an oral steroid bolus and taper. If they have a reduced EF, you're going to be a bit more aggressive, IV steroids, add some IVIG if it's AMR. And if they're in heart failure or shock, you're not going to wait for the biopsy. You're going to throw the kitchen sink at them. And that will include IV pulse steroids, cytolytic therapy with ATG, which is formed by given most commonly rabbits human thymocyte, and then they make antibodies to T cells, B cells, plasma cells, plasmapheresis, which removes preformed potentially cytotoxic antibodies, IVIG, a polyclonal preparation that blocks antibody function, IV heparin. Why IV heparin? Well, autopsy series of patients who die of acute rejection has shown thrombus in the coronary microvasculature, so we give IV heparin, and oftentimes these patients are so sick they end up on a balloon pump or temporary MCS anyway, for which heparin is required, and of course inotropic support all the way to extreme temporary MCS as a bridge to recovery to give the time for the rejection medications to work. So in this case, the hemodynamics deteriorate with recurrent VT, a balloon pump is placed, dobutamine and furosemide started, the VT gets better, and now her RA is 10, PA 30/20, wedge 20, index 2.5. You've bought yourself some time, and you start the therapy with the methylprednisolone, ATG, plasmapheresis, IV heparin, and the next day, the biopsy shows the characteristic findings of antibody-mediated rejection. Now, disclosure, my mother is a pathologist, but sadly, that type of knowledge is not genetically inherited, so I need the arrows and the labels to tell me what I'm looking at. So on H&E staining, you'll see intravascular lymphocytes. On immunostaining, you'll see prominent macrophages, rare T lymphocytes, because this is a B-cell mediated process, and you'll see that these macrophages are intravascular as CD34 stains for the endothelium, and you'll see complement deposition in the capillaries. So really classic for the diagnostic criteria for antibody-mediated rejection. It's now been over a decade that the new criteria were put into place, where the biopsy specimens were stratified based on the presence or absence of immunopathology and histology. So the biopsy is either negative, suspicious if one of these two abnormalities is present, or positive with a criteria for severe destructive changes. So we get worried about PAMR1 and we pay very close attention to PAMR2 or 3. So
Dr. Kittleson, I'm really sorry to interrupt. I've got some feedback that some of our virtual attendees aren't hearing you very well. If you could possibly be closer, I'm really sorry to bug you.
I'm so glad you weighed in. I don't want you to miss a single pearl of all the knowledge I'm dispensing.
Absolutely.
So I'm going to move a little closer to the screen, and I'll make sure to speak up. Thank you. Please interrupt again if people can't hear. Beautiful. Thanks. So what I want to focus the rest of the talk on is the challenges of antibody-mediated rejection. How did this patient get to where she is? Let's talk about prevention. How do I identify patients at high risk for AMR? Can high-risk patients be treated prior to transplant? And then treatment. How should AMR be treated? And if the initial therapy fails, what do you do next? So we will start with a one-slide brief foray into basic transplant immunology, or as I like to put it, transplant immunology that even a cardiologist like me can understand. So as we know, there are two forms of rejection. There's cellular rejection, where CD4 and CD8 T cells target the donor human leukocyte antigen, HLA, present on all nucleated cells, and then they're transformed into cytotoxic T cells, which results in cell damage. In contrast, there's antibody-mediated rejection, where B cells are activated to plasma cells, which make antibodies against HLA, which results in complement-dependent cytotoxicity. B cells, plasma cells, antibodies, complement. I highlight these because, as you'll see through our discussion, these are our therapeutic targets when we consider patients who are sensitized or having AMR. Now, the first step, of course, is going to be prevention. So the targets of the antibody response are these human leukocyte antigens, class 1 present on all nucleated cells, class 2 present on antigen-presenting cells. And the risk factors for sensitization will be any time that a person is exposed to foreign HLA, which can happen through blood transfusions because some nucleated cells sneak in, through pregnancy, not just delivery, but any pregnancy is a risk factor. previous transplants, and mechanical circulatory support devices, which are likely sensitizing events even independent of blood transfusions received. And the goal is to identify sensitized patients prior to transplant. And we do that by the screening, identification, and characterization of the anti-HLA antibodies. Now, you'll hear this referred to as the panel reactive antibodies, or PRA. That's a historical term, because back in the olden days, they used to take a panel of serum cells from volunteers and then test heart transplant candidates, other solid organ transplant candidates' serum against this panel of volunteers who gave their cells. There's also non-HLA antibodies, which are a bit more experimental. I'm not going to focus on those. But let's talk about the PRA, the anti-HLA antibodies. Screening, are there any? Identification, which ones are there? And characterization, how bad are they? So the first step is, are there any? And in fact, even this question, are there any present, has prognostic value. This is a classic study now from the UNOS registry looking at pre-transplant PRA and post-transplant outcomes, and even looking on this most basic level. If you have a high PRA, you have decreased survival up to 5 years. So we know that this portends risk. But the next question is, which ones are there? And we determine this with the solid phase immunoassays using most commonly the Luminex platform, which has antigen-coded beads. Each bead has a different HLA antigen on it. Then you pass the heart transplant candidate serum through this column containing antigen-coded beads. Antigen antibody complexes will bind, are then tagged with a fluorescent carrier, then pass through a flow cytometer, allowing the detection and identification of exact HLA antibodies. And the next question you want to know is, how bad are they? And the most common way to characterize how bad these antibodies are is with the mean fluorescent intensity, or MFI. Now, there will be center-specific thresholds for what constitutes a weak, moderate, or strong antibody. These are the ones we use at Cedars and the ones that I'll use for the rest of the talk. So moderate, 5 to 10,000, strong, above 10,000. But there's other ways to characterize the importance of an antibody, because what you really want to know is, if I give my patient a heart for which they have an antibody, are they going to kill the new heart? And so using MFI is one marker of how deleterious or detrimental this antibody can be, but there's other ways. There's dilution. Is it still present after serial dilution? That's a nice method. It is a bit more expensive because you have to do a lot more tests. And there's also C1q binding. So let's talk about the C1q assay. So, I went into cardiology because I thought I'd never have to remember the complement cascade, and life comes full circle, and now I have to know the complement cascade. So as you remember, the way this works is antigen antibody bind, that then activates the C1 complex, which leads downstream through the complement cascade to the formation of the membrane attack complex, then cell lysis and death. But that first step, the anti-HLA antibodies antigen complex has to fix complement, has to bind C1q to be cytotoxic. So identifying which anti-HLA antibodies are C1q positive can theoretically refine the prediction of potential cytotoxicity. This was shown very elegantly some years ago by Dr. Alex Lupi, a transplant nephrologist from France. And of course, it's an elegant study because he's French. And what they showed was, when you took kidney transplant recipients who had donor-specific antibodies, those antibodies that were C1q positive led to far worse graft survival than those that were C1q negative. This has been replicated somewhat in other studies, but remains a really nice proof of concept of the potential role of the C1q assay. So putting all of this together, we have a protocol for sensitized patients. Step 1, assess for the presence of anti-HLA antibodies. Are they there? How strong are they? What's their function? So anti-HLA, MFI, dilution, C1q, and then decide, are there significant antibodies? And the thresholds will be center specific. But we say if your MFI is above 5,000, if they're present after dilution, or if they're C1q binding, that's significant. If there are no significant antibodies, we'll recheck every 6 months on an outpatient, every 2 weeks on an inpatient, or 2 weeks after a potentially sensitizing event like infection, vaccination, transfusion. If significant antibodies are present, then we have to decide what to do with that information. And the first thing we do is determine the calculated PRA. So the calculated PRA is what matters clinically, because it answers the question, how easy will it be to find a donor for my patient awaiting transplant? It defines the frequency of the unacceptable HLA in the donor population. So I've given you a sample PRA report here. It gives you the class 1, it gives you the class 2, and I've highlighted in colors everything with an MFI above 5,000 because that would be considered moderate or above. So this first step in performing a calculated PRA is to say, what's unacceptable? What would I not want to cross? What donor would I not consider if they have that antigen? Let's just say, for the sake of argument, we say MFI over 5,000. So those 6 are out. We don't want a donor with those. The next step is to determine the frequency of those in the population. And so you Google CPRA calculator, you come to a website and you click on the ones you're going to avoid, and it spits out a number. Here, let's say 80%, it gives you a nice little graphic, which tells you that's bad. The higher the CPRA, the worse for your patient. The CPRA of 80 means only 20% of donors would be a match. It tells you that if for every 5 donors that come up for your patient on the waiting list, maybe only one of those 5 is going to be immunologically okay. But what you're going to think right now is, but this all hinges on step 1. How do you define the unacceptable HLA? Say we changed our mind and said, well, now let's just say potentially cytotoxic if they're C1q positive, and only the 2 in red happen to be C1q positive. Now your CPRA has gone from 80% to 32%. Wow, now if every 3 donors that come up, maybe 2 out of 3 will be okay. So it's a balance, because how you define things, if you define them by a higher threshold, you might get more donor offers, more potential for rejection, and you have to balance those risks. So one exciting new hot off the press advance with the CPRA calculator is that a brand new one is coming out on November 30th, 2022. So just in 2 weeks. The current calculator is based on 15,000 deceased kidney donors between 2007 and 2008, but it doesn't include some very important loci. So the new calculator has a lot of advantages. It includes the DQA, DPA, DPB1 loci. Second, it uses many more ethnic groups, much more variety, and it uses far more donors, 6.6 million donors for the National Marrow Donor Program. And as this very nice article showed last year from one of my awesome colleagues, Dr. Evan Kransdorf, that you see that reclassification isn't that great. It's still quite accurate, but we'll get a far better assessment of the CPRA for our population. So I told you before that having a higher CPRA is bad, right? Because if the higher the CPRA, the less donors theoretically are available. But it's not just theoretical. It was actually shown very nicely, again by Dr. Kransdorf, in this beautiful study of the UNOS registry, where he stratified patients by their pre-transplant CPRA and found that if your CPRA was above 80, you had a longer wait time, you had a far lower chance of ever getting transplanted, 70% less chance of getting transplanted, and a 2-fold increased risk of dying or being removed from the wait list, because everyone knows that time on the wait list is borrowed time. And so the longer you wait, the more chance something horrible is going to happen to you while you're waiting, and having sensitization and elevated CPRA increases that wait. So putting this together, we've talked about the fact that if there are significant antibodies present, we'll determine the calculated PRA, And what do you do next? Well, then you have to decide, are you going to do something to try to bring that CPRA down? And our general practice is if the CPRA is above 50%, meaning maybe only one of every 2 donors is going to be a match, we will do desensitization. There are a lot of different desensitization protocols out there, and they target many different parts of the immune system as shown here. And I'll tell you the general themes is that these are all stolen, adapted from the renal transplant experience. If it seems to work for kidneys, we will try it in hearts. Since the pool of kidney transplant candidates is so much larger, they can do far more studies than we can do in the relatively smaller world of heart transplant, targeting various steps of the antibody response, whether it's the antibodies, the plasma cells, the B or T cells, and they vary in their duration and the intensity of the logistics involved, as we'll discuss. So let's start with one of the easiest protocols to do logistically, and also historically one of the first protocols, which is IVIG and rituximab. Again, adapted from the renal transplant experience. This is the classic New England Journal paper from Stan Jordan, one of our Cedars transplant nephrologists and colleagues, where they took sensitized kidney transplant recipients. They found that their PRA came down 77% to 44%, and that their graft function up to 12 months after transplant, as measured by serum creatinine, was good. The components are plasmapheresis, remove the antibodies, IVIG, block the antibodies, rituximab, block the B cells that make the antibodies. And the protocol is essentially a 30-ish day protocol where there's IVIG, rituximab, more IVIG, and then about 2 weeks after the IVIG, you can recheck the antibodies. Now, this protocol was great when it first came out. It offered hope to patients for whom we had nothing to give them, but it didn't work perfectly. And this is a sample of a patient. So this is 2009 I'm showing you this figure from, because when the study came out in 2008, we basically gave it to every sensitized patient. And we found that there were patients who had persistently elevated PRA despite the IVIG and rituximab. And so this patient had a drop after the first round, a rebound after the second round, and he was actually a redo transplant candidate stuck in the hospital with no options. And we said, well, let's try something new. So we tried a magical, new at the time strategy that plummeted 4 of his 5 problematic antibodies down, and he was ultimately successfully transplanted. And the next therapy in our armamentarium was bortezomib. So the plasmapheresis bortezomib protocol includes the proteasome inhibitor bortezomib that targets plasma cells, as we all know, FDA approved for multiple myeloma. And in the Cedars-Sinai experience that we published about a decade ago, we took patients who had these refractory antibodies, and we found that for 6 of the 7 patients, we were able to bring down their CPRA from about 65% to 35% and get them successfully transplanted. There were infections, there was neuropathy, and the one who didn't make it got a second cycle and died from sepsis, which taught us the law of diminishing returns. There's no such thing as a free lunch when you give desensitization, especially if you repeat cycles. But the protocol, most easily done as an inpatient, is 2 weeks of plasmapheresis and plasmapheresis plus bortezomib. Now we got very excited about this in the early 2010s, and we're sprinkling plasmapheresis bortezomib around like water. But we found that there were patients who had persistently elevated PRA despite IVIG, rituximab, and bortezomib. And this is a sample of one of those patients. So the CPRA is in the blue dot. And as you can see, it's basically hovering around 100. She got IVIG rituximab, didn't do anything. She got carfilzomib, which is essentially a bortezomib cousin, didn't do anything. So what were we going to do with this woman? Well, she actually worsened and needed to be listed status 3. So now she's stuck in the hospital with a CPRA blue dot hovering around 100%. And we gave her some stuff, as you can see here by those orange dots. We gave her some monthly stuff. And after the 3rd dose, her CPRA plummeted, relatively plummeted, to around 70%. There was a window of hope. And around the same time, she'd been listed status 3 now for almost 4 months, started to worsen. She needed a balloon pump, and the stars aligned. Her urgency increased. At the time her antibodies fell, she underwent transplant, was home 10 days later. It was incredible. It was incredible to take this woman who was so refractory to everything and actually give her some hope. And that magical therapy we gave her was tocilizumab. So let's talk about tocilizumab. It's an anti-IL-6. IL-6 promotes inflammatory events, including expansion and activation of T cells, differentiation of B cells, antibody production, kind of a one-size-fits-all. And if so, we care about those T cells and B cells. In data, again, still stolen from the kidney transplant literature, we see that when you give this IL-6 antagonist, tocilizumab, you can bring down donor-specific antibodies, as seen in the figure up top, and you also reduce the risk of recurrent antibody-mediated rejection. The protocol, this is the downside, is monthly, and it takes usually 3, maybe 4 doses before you will see a benefit. But it's certainly been something we now use on a case-by-case basis for those highly sensitized patients for whom nothing else has worked. So that brings us to determining the calculated PRA, using that information to decide on desensitization protocols. And this is all the stuff you do in the planning phase, when your patient is sitting there on the wait list and you want to do everything in your power to minimize their wait time, widen the donor pool, get them safely through transplant. But what do you do when a donor is actually available? That brings us to the cell-based versus the virtual cross-match. So finally, you have a patient, you're aware of all their antibodies, the identity, strength, and function, and now you have a donor. Is that donor an acceptable one for your candidate? So one way to figure that out is with a virtual cross-match, which occurs by definition by being virtually on paper, where you avoid donors with HLA, for which the recipient has strong anti-HLA antibodies to then hope to prevent hyperacute rejection. Process. First, you have to, again, define what do you consider cytotoxic, what you're predicting the future, and then avoid those donors. So, for example, if we said everything in orange or red is not acceptable, and a donor came up with one of those, you would reject it on paper. Now, it kind of depends on how you define risk. Do you feel lucky, right? What if you only said no to the ones in red? And if there was one of the ones in orange, you said, I'm going to take a chance, let's go for it. Well, you're going to get more donor offers, possible risk of rejection. You have to balance how sick is the patient, how important is the transplant, how urgently do we need to go. But ultimately, a virtual cross-match is very unsatisfying for those patients who are highly and broadly sensitized, right? If you only have 1, 2 high-level antibodies, maybe you feel comfortable just doing this dance on paper. But if you've got multiple antibodies, you don't want to cancel out the entire donor pool. You're going to do a cell-based cross-match instead. This happens in real life. You avoid donors with HLA to which the recipient has cytotoxic anti-HLA antibodies to prevent hyperacute rejection. You test recipient serum against donor cells. Of course, there's geographical constraints that limit the donor pool because you have to bank your recipient serum at various OPOs, so that limits you geographically. But it's what we use in those broadly sensitized patients, roughly defined as a CPRA above 50%. Now, if you do the cross-match, there's 2 ways to do it. So as we said, you've got the recipient sera containing anti-HLA donor-specific antibodies. You will mix this with donor lymphocytes, and then one of 2 things will happen. You can add complement and see, do the cells die? So that's a CDC, or complement-dependent cytotoxicity cross-match. That tells you, whoa, antibodies are present and they can kill. I like to call a CDC cross-match hyperacute rejection in a test tube. This is something you would want to avoid at all costs. But there's a second way to do the cross-match, and that is a flow cross-match, which tells you antibodies are present, but it doesn't give you any sense of the killing potential. So, I like to say the definition of insanity is doing the same thing over again and expecting a different result. So a CDC crossmatch is essentially a contraindication to transplant. If the test tube has hyperacute rejection, let's not replicate that experiment into human. What about a flow crossmatch? Is a positive flow crossmatch bad? Well, let's look at some data. Let's look at some data from 2 decades ago. That's the figure on the left. And you see that a positive flow crossmatch led to decreased survival. Now let's look a decade ago when you could give stuff like IVIG and rituximab to patients to try to counteract the effect of a positive flow crossmatch. Now you see survival's okay, but there is an increased risk of rejection. So what do? How do you put this all together? So say you've got this CPRA that's high, you're doing your crossmatch, including the CDC. If it's negative flow and negative CDC, you celebrate, you proceed with the transplant. It's positive flow, positive CDC, you will not replicate the test tube experiment in the human, and transplant is generally contraindicated. But what do you if the flow is positive and the CDC is negative? You could proceed with caution with use of ATG, plasmapheresis, IVIG, rituximab, and what we have done at Cedars-Sinai in this situation is using eculizumab. So let's talk about eculizumab. And if you thought you were only going to see the complement cascade figure once in this talk, think again. I'm showing it to you again. So eculizumab is a humanized monoclonal antibody that binds to and prevents activation of complement component C5. So remember, antigen-antibody complex binds to C1q, cascade, membrane attack complex, cell death. But right before the membrane attack complex is C5. So eculizumab, by inhibiting C5, cuts the complement cascade off at its knees. It's like you've got the gun and you've got the bullet, but they can't go together and they can't kill the cell. Now, it's FDA approved for paroxysmal nocturnal hemoglobinuria. It's also used for atypical hemolytic uremic syndrome, which are complement-mediated processes, and repurposed for this highly sensitized patients. So we completed last year before, the DUET cardiac study, which was the de novo use of eculizumab in an open label pilot at Cedars-Sinai. We had 20 highly sensitized patients. They had to have a positive flow crossmatch with at least one DSA at the time of transplant. They received eculizumab on release of aortic cross clamp in the operating room, and then they received more eculizumab weekly for 7 weeks. So what happened to these patients who would have otherwise never been able to get a transplant? Well, they did pretty well, actually. 90% 1-year survival. They all had donor-specific antibodies. Of course, they weren't going to go anywhere. No cellular rejection. Again, not a surprise, because why would we expect cellular rejection? But also not very much antibody-mediated rejection, and no graft dysfunction at the cost of infections, C. diff, UTIs, that sort of thing. But I know what you're thinking. You're thinking, fine, these 20 patients did great, but maybe they'd have done just as well without the eculizumab. So we wanted a control group to figure that out. So we went through our database of patients who were highly sensitized with a positive flow crossmatch pre-eculizumab to compare. But we couldn't find any, because before eculizumab, we were too chicken to transplant against a positive flow crossmatch. But our colleagues in France were far more courageous and provided us with a control group of patients with a positive flow crossmatch, at least one DSA, who were transplanted without eculizumab, were given plasmapheresis IVIG, and lo and behold, when you compare them to this control group, you see less antibody-mediated rejection, less number of AMR events. So truly, eculizumab has become hope for the highly sensitized. So that takes us through prevention of antibody-mediated rejection. How do we identify those patients who are high risk? Can they be treated? Now let's talk about treatment. Let's go back to our case. This 35-year-old woman, 4 months post-transplant, nausea, vomiting, fatigue, cardiogenic shock, balloon pump, inotropic support, AMR on biopsy. She's given methylprednisolone followed by a pred taper, ATG, plasmapheresis before the ATG dose, so you don't freeze the ATG away, followed by some IVIG. Over the next week, the balloon pump is removed, the heparin is stopped, the inotropes are weaned, the PA catheter comes out, her ejection fraction is now 40%. Congratulations, you saved her life. What happens next? Well, you could list her urgently for retransplantation, you could change your immunosuppression, you could repeat the biopsy, you could start Coumadin. Well, Coumadin's not needed, right? She needed IV heparin in the throes of cardiogenic shock, but it's not like she has thromboembolic disease or AFib now that needs long-term anticoagulation. Urgently for retransplant, you're not going to do that for two reasons. Number one, it's not clear she's sick enough. And number two, it's a relative contraindication to transplant someone when they are having an active rejection episode because the immunological milieu is so ramped up that they're likely just going to reject the next heart. But we'll talk about changing immunosuppression. So the proliferation signal inhibitors, sirolimus and everolimus, inhibit the proliferation of T, B, smooth muscle cells, endothelial cells. That's why they work so well in those drug-eluting stents. And in clinical trials, less rejection, less allograft vasculopathy, less viral infections like CMV, at the cost of more nephrotoxicity when combined with the CNI and impaired wound healing. This is why we don't blanketly give it to everyone, but certainly for an indication of rejection, we would. So in this patient, the MMF is stopped and sirolimus started. In clinic 1 week after discharge, she feels better. Heart rate's 120, blood pressure 110/80, EF 45%, RA 15, PA 30/20, wedge 20, index 1.8. Biopsy shows no cellular or AMR, and she's a new DSA to DQ7 with an MFI of 8,000 that is C1q positive. So you're happy because she feels better, her EF is better, and her biopsy is negative, but you're sad because she's tachycardic with elevated filling pressures and a low index consistent with restrictive physiology and a new, strong DSA. So what should we do next? Can we just ignore the PRA because she had IVIG? Can we repeat the biopsies per protocol? Should we start photopheresis? Should we give her some desensitization? Well, we'd like to ignore the PRA, like we'd like to ignore everything in life that doesn't fit our optimistic worldview. But sadly, if you've waited 2 weeks after the IVIG, they will be accurate. And there is prognostic value of the post-transplant PRA. These studies are old, but no less true. And they all show if you have donor-specific antibodies after transplant, you're going to have more rejection and decreased survival. So you want to do something. What could those somethings be? Photopheresis is an option. You might not know that photopheresis was actually invented by the ancient Egyptians who found that the leaves of a certain plant caused vitiligo to improve. And what it was vitiligo, as we all know, is an autoimmune condition mediated by T cells against melanocytes. And this plant contains sorolin, which intercalates into the DNA of rapidly dividing cells, and when exposed to UV light causes them to die. Essentially, they were performing a form of phototherapy. How this works for transplant recipients in the current era is, of course, far more expensive and involved than for the ancient Egyptians. There's leukophoresis, remove the white cells, photoactivation, mix them with sorolin, exposed to UV light, which leads to apoptosis and reinfusion. It's quite mysterious in that it only actually impacts a small proportion of the circulating T cell population, yet somehow acts as a immunomodulation that has been tested in primary prevention and recurrent rejection and shown to be of benefit in these older trials. So that's an option in addition to the option of desensitization. So after the dust settles, 2 weeks after treatment for rejection, we'll repeat the echo, the biopsy with right heart cath, and the anti-HLA antibodies. If there's a normal EF and normal hemos and no DSAs and no rejection, we'll tell the patient to not buy a lottery ticket. They've already won the jackpot. They get routine surveillance. They emerged unscathed from AMR. If, on the other hand, there's a persistent low EF or abnormal hemos or donor-specific antibodies or persistent AMR, they're going to need something for this smoldering process, the gift that keeps on giving. And we'll give them something, IVIG, Rituximab, bortezomib, tocilizumab, photo. No one knows the right answer in this situation, but I have to say we have moved towards some long-term maintenance that tends to be generally tocilizumab or photopheresis, because we feel somehow reassured by that 6-month quelling of the immune system. So in this case, due to her persistent restrictive physiology in DSA, she received photo. She had some fluid retention, which is a known side effect of sirolimus, though it could have just been her restrictive physiology, but it was stopped and MMF restarted. Her DQ7 DSA persisted, and her first annual coronary angiogram demonstrated mild luminal irregularities. Now, if you're glass half full kind of patient, you'll say, meh, everyone's got a few luminal irregularities. If you're a glass half empty person, or as I like to say, a realist, you will say this is a harbinger of things to come from the endothelial injury that happened at the time of her AMR. And this is not her, but a representative example of beautiful, plump, healthy coronaries on the donor. And then they get whittled away quite rapidly over time through this inflammatory process that can be part of allograft vasculopathy. And in fact, in this patient, 2 years post-transplant, diffuse CAD, low EF, no rejection as the cause of her low EF, listed for redo transplant, progressive hemodynamic compromise, listed with status 1A historically, would be status 3 currently. Her CPRA was not high. She didn't have a ton of antibodies, just the ones she had were bad for her heart. And she didn't need desensitization. She was listed with a virtual cross-match. Post-transplant, she got some induction, because that's our standard for all redos, and had standard immunosuppression. Switched to sirolimus at 6 months as insurance that perhaps this wouldn't happen again. Standard biopsy protocol and PRAs every 6 months. So this story does have a happy ending. It is a happy ending at the cost of a need for a new transplant. So that then takes us through treatment, how AMR should be treated, and if the initial therapy fails, what do we do next? So in summary, what we've covered today, when it comes to the prevention of AMR, remember assays to characterize the HLA antibodies, including dilution and C1q, how you use this information to determine the CPRA and the need for the cross-match, and that desensitization strategies target many areas, many components of the process, including B cells, plasma cells, and antibodies. And when it comes to treatment, the key really is to remember the smoldering consequences, and long-term maintenance options may be required. So I'd like to thank you so much for your attention. And before I finish, self-promotion makes me a little uncomfortable, but I'm going to do it anyway and let you know that I actually have a book coming out that is based in large part on my philosophy of hashtag Kittleson rules on Twitter, and it will be published on January 7th, 2023. So make sure you buy a copy for your favorite trainee. Thank you so much for your attention. I'm happy to take any questions.
Dr. Kittleson, that was phenomenal, phenomenal. Thank you so much. And we'll open it up for questions, but maybe I can go first. Can you speak a little bit in terms of long-term outcomes for patients post-desensitization? People who have, super high PRAs, you get them through. How do they do long-term?
It's so interesting to me that what we seem to find is when they have, and when we do our CPRA as a decision then to figure out desensitization, cross-match issues, we use the most recent PRA. I mean, if you have an old PRA from when we first met you, and then we desensitized you and that all went away, we consider that ancient history and just go by what we have in front of us. And what is so amazing and remarkable to me is that post-transplant, they tend to persist in some cases, especially those highly sensitized ones that get eculizumab. But over time, and whether it's just the maintenance immunosuppression, plus minus some patients who will get other stuff after transplant, like the IVIG, Ritux, bortezomib, tocilizumab, by the time they're a year out, in almost all cases, they fade away. And whether, like I said, it's the maintenance immunosuppression on top of everything else we've thrown at them, we find that, and then those early ones, those historical ones that we got rid of right away, don't come back. So when we think about at the pedals to the metal, you have a donor for your recipient. Which antibodies do I care about? We don't go back to the ancient history of what exists before. We go by the most recent results of the current desensitization. And post-transplant, we find they tend to go away in almost all cases.
Wonderful, really interesting. And you find, I guess, presumably similar longevity and durability of graft function congruent with that?
There's no question that sensitized patients are at higher risk for AMR, and there's no question that patients with AMR are at a higher risk for CAV. No question. But it's sort of balancing in a way, a rock and a hard place, right? Maybe you're not going to live 30 years after transplant. I don't know. I mean, these things are relatively new. Maybe we'll have some of those. But if I can give you, and we know 90% survival in 1 year on those eculizumab patients, and now those patients are now out, we have 90% survival at 2 years. To me, that's still worth it. And I think if you were to look at global strategies, there's no question that patients with AMR or patients who are sensitized probably have worse survival than patients who are not. But the question is, how much worse is acceptable or not acceptable? And there's two ways to look at that. I think number one, we know there are certain categories of patients who've got worse outcomes. Redo transplant patients have worse outcomes, but we still transplant them. And so you have to sort of balance that risk ethically and the pool of donors. The second thing is, I think it's every program's acceptance of risk, right? We're all beholden to those observed versus accepted metrics. And I think risk begets risk, and that the more volume you have, the more risk you're willing to take, and then you take on those cases. But there's certainly an element, I think, in every program of anchoring bias, in the sense that if my last 3 patients didn't do so well, this 4th one likely isn't going to get through. So I think every program has to balance all those competing interests when it comes to the patient in front of them.
Understood. Thank you. We've got a question from one of our transplant cardiologists. Dr. O'Neill, do you want to come off mute and pose your question?
Sure. Yeah, thanks. That was great. I just wanted to ask, what are your thoughts about how you think about class 1 versus class 2 antibodies, whether it's a pre-transplant patient or, and then as someone who's got, maybe high antibodies post-transplant, especially that isn't actively rejecting?
Yes, that's $1 million question. I think, there's so much data that shows us so many different things that generally our approach is just treat them all the same. I mean, in A1 and A2, we think are particularly evil antibodies as the class 1s, and they're also very common in the population. You wish your patient didn't have them. But by and large, we consider them all the same when we're deciding on desensitization, and they're all treated equally in the CPRA calculator. The second thing I would say is when it comes to post-transplant, so our post-transplant protocol for every patient, whether sensitized pre or not sensitized pre, is to check the PRA every 3 months in the first year and every 6 months for life. And honestly, I have some angina about that, because I have a belief in this world that you shouldn't check a test if it won't change your management. That's Kittleson rule. But we still check them, and we don't know what to do with the information. So in a way, you're learning as you're going. So what if the situation you mentioned comes up? What if you have a patient who wasn't sensitized, who's been doing great, and all of a sudden 6 years post-transplant on a routine random PRA check has a new DSA to DQ7? And it's high level, it's C1q positive. If they're low level, maybe we'll just ignore. We'll say accommodation, everything is fine, live your life. The very least we would do is switch them from MMF to a PSI, because at least we feel we're doing something relatively benign to prevent rejection moving forward. What else might we do? Would we actually biopsy them? We may go so far as to biopsy them. What we've been using more often these days, now that we have the technology, is the AlloSure, the donor-derived cell-free DNA. Because presumably, it should be undetectable when you're 6 years out from transplant and feeling great. If it's high, is that a sign of early graft injury? And what we found is often it is high, and then the biopsy is negative, and then you're still left in a situation of what am I supposed to do with this information? So I would say MMF to PSI transition is pretty much de rigueur for any patient with a new DSA, especially a strong one. what you do if you end up doing a biopsy and there's no rejection, but you're in this weird situation where the AlloSure is positive, we do kind of make it up as we go along. And it depends on how the patient looks. They're 78 and kind of frail and they have a lot of infections. Maybe we just let them be. They're 32 and they feel amazing and they're very robust and they haven't had any issues. Maybe we should give them something. And is that something going to be tocilizumab, which has the advantage of being pretty mild, not a lot of side effects every month for 6 months? You know, I truly, it is a work in progress. It is an art. It's not even really a science, but that's our approach to that situation.
Thank you. We've got a question from one of our transplant cardiologists, Dr. Joe. Do you want to come off mute and post your question? Thanks, David.
Yes, thank you, Dr. Kittleson, for this talk. One persistent issue that seems to come up for our group is the sensitized patient with the calculated PRAs, 80s, 70s, 90s% range. And we don't have a desensitization protocol here, specifically with, say, eculizumab, which you use extensively at your institution. I guess, do you have any advice for any programs who are thinking about taking this on, who perhaps have less volume than you guys do at Cedars, about instituting protocols with, say, eculizumab and other similar things?
Yeah. It's a great question. And, you know, I think it is very difficult because, again, we're tied to our metrics. We're held to those metrics, and it's very hard to take risk when you know all you want to do is the right thing for the patient in front of you, but you also do the right thing for your whole program. So I would say this. I put desensitization to a little bit of a different bucket than eculizumab, but you're right, they go together. And eculizumab is our safety net for those patients who might not have had such great desensitization results, and now they've got a positive flow cross match. So there's a couple different philosophies, right? You could say, I don't know about this voodoo desensitization stuff. You do it, maybe it works, maybe it doesn't, it's really expensive, how you get insurance to cover it. Don't even do that at all. Just take your sensitized patients, list them with a cell-based cross-match, and then if it's a positive flow, throw in some eculizumab and hope for the best. The other problem with eculizumab is it does cost $30,000 a dose. So you need some buy-in by your hospital pharmacy, administration, etc., to make sure that they're willing to go in for that as well. The second option is to say, okay, eculizumab's way too expensive. We just can't, we'll never go against a positive flow cross-match. If we do, we're just gonna use the other old school stuff. But let's try this desensitization stuff, because you know what? IVIG Ritux is really quite benign. Plasmapheresis bortezomib, probably more risk of rejection, but still it's only a 2-week protocol. You're gonna get an answer pretty fast if it works. And tocilizumab, while it's 6 months, might be nice for an outpatient sensitized VAD patient, because again, it's pretty gentle on the infection front, so maybe try that. And then work, and I think the best way probably to do it is to pick a really relatively low risk patient. Like their CPRA is 50 to 70%. And they're an outpatient with not a lot of infections and is relatively robust, and then experiment with these desensitization protocols and see what happens. Meaning the first patient probably shouldn't be a CPRA of 100% because then you're just going to be demoralized. So then you start with someone who's maybe more likely to work with it and is less likely to have a side effect from it, and you go from there.
And I just want to thank you. I just want to underline what Dr. Elam has raised in our chat, that Dr. Kittleson and her team have really partnered with us beautifully over the years, and we are really appreciative of that. We are joined by our colleagues across the country at Yale, Summa Health, Northern Health, Brigham and BIDMC in Boston. And we've got a question from Dr. Bellamkonda at Yale. Dr. Bellamkonda, do you want to come off mute and pose your question directly?
Yeah, thank you so much. Michelle, that was a wonderful talk as always. So thanks for that excellent run through from pre-transplant to post-transplant. My quick question is, in that chart and flow diagram, you've talked about using induction if the flow is positive after desensitization. How about those that are have high PRAs, more than 50%, but flow is negative? Do you still do some ATG or something like that, or do you just let them be?
Great point. So we are not a blanket induction program where you use induction on case-by-case basis, but you're exactly right. Anyone who's sensitized in any way, even if their flow is negative, is going to get ATG. Now, how do we define sensitized in any way? It almost depends on which attending is on service and how much you love ATG. Some attendings will do it if the PRA is above 0. Some will do it if the PRA is above 20. But sort of that's the general sense. Any kind of antibody. And of course, the second reason would be is if you want to delay the CNI because you're worried about nephrotoxicity. So you start the ATG so you can put the CNI on a few days later. But those are the two reasons that we would use it in our program. And it's great to see you again. I haven't seen you in a while.
We've got a question from Dr. Gordeski, our division chief.
Yeah, Michelle, thank you again for the lecture and for supporting our program over the last few years when we have questions. Any randomized clinical trials related to desensitization that are going to be rolling out on the national stage that we need to know about or maybe even become a site for?
Yeah, what a great question. We have 2 center-specific randomized trials currently ongoing, single center. One, we're using tocilizumab for induction therapy, and we're using ATG for induction therapy. Both of them are enrolling patients who would not otherwise need induction, who are being randomized to one of those 2 strategies. So not pertinent to the sensitized universe. And none that I'm aware of in sensitized patients, but you hit on the heart of the matter, no pun intended, which is, gosh, what are we doing here? Where all of our data is based on a case anecdotes, case after case after case. I mean, that's really the hierarchy of evidence in the world of heart transplant sensitization. So what I would say, though, is if you want to design a randomized trial like that, the question is, number one, can you randomize against placebo? It's kind of hard to not give anything to a highly sensitized patient. Number two, what are your endpoints going to be such that you can power it? Because you really want an endpoint like mortality on the wait list or mortality after transplant. But that's going to be our clinically relevant CAV, but it's either going to take too many patients or too many years to get an answer. So you're probably going to end on something like the DOSE trial, which had those really weird endpoints of global assessment of symptoms at 72 hours for furosemide, right? Because they needed to power it to have 300 patients. I think you'd end up with an endpoint that's probably not as meaningful. So I agree with you, we need those trials, but I worry about the logistics and the feasibility of actually doing them.
Well, you know, you said you may not want to randomize highly sensitized patients, but you're speaking from your perspective and your lenses where you're sitting at Cedars. And as you know, around the country, there are programs that list people who are highly sensitized and wait. And you even mentioned it in the lecture. So maybe there is equipoise even, you know, because the center behavior is so variable around the world in the country.
But what I'd say to that, and I totally agree, is will there then be buy-in? Because there's such entrenched center-specific traditions to randomize or not from the centers that always do and the centers that always don't. And I worry about doing like a cluster trial where it's center versus center, because there's so many other variables that I still worry it wouldn't be feasible. But I'm the, what's that guy's name? I'm like remember the grump on the Muppets? I'm always the curmudgeon and skeptic. So I think, but you're right, we cannot answer this question on a center alone basis. It has to be a collaboration.
And maybe just one last question before you leave us. Our fellow wondered, beyond, you know, this kind of monitoring post desensitization with AlloSure, what is the Cedars experience with AlloSure, you know, pre and post? Where does it fit into your algorithm?
Yeah, so we started when AlloMap came out with the gene expression profiling, and now we do the AlloMap and the AlloSure, the donor-derived cell-free DNA. So for post-transplant management, this is how we do it. If you are a highly sensitized patient, especially what's the marker for that? Again, it's a little bit, if you've gotten eculizumab for sure, you will never see an AlloMap or an AlloSure as part of your routine surveillance. You will be a biopsy only protocol, and we do biopsies up until the first year per protocol. After the first year, it's pretty much symptom driven only, weekly for the first 4 weeks, then every other week, then monthly, then bi-monthly until you're a year out. What about if you're a low risk patient, not sensitized, we're not worried, not had any issues? Then you will get a biopsy week 2, week 4, month week 2, week 4, week 6, month 3, month 6, month 12. And at other times, once you're more than 3 months out, you will get the AlloMap AlloSure. So you'll get it at month 4, month 5, months 7 through 11. And the rationale being, if you're already at low risk for rejection, we can trust this as a screening tool with a high negative predicted value to avoid an unnecessary biopsy in those low risk patients. What we tend to find, and I don't think this is published yet by any group, is that I think the AlloSure seems to be more useful than the AlloMap, and not just because AlloMap is just engineered for cellular rejection, but we see a lot more false positive AlloMaps than we seem to see false positive AlloSures. The one difficulty and challenge is dual organ transplants. There isn't necessarily a set threshold, and it's definitely higher, and so we sort of set a higher threshold but are not exactly sure. And then just a random anecdote, we have a patient who's undergone a stem cell transplant in the past and has a chemo-related cardiomyopathy, and his AlloSures are always off the chart. And there's something about that dual transplant or prior transplant that affects the results.
Fantastic, fantastic. Well, Dr. Kittleson, Michelle, thank you so much for years of collaboration and for an outstanding lecture. You drew people across the country to your feet to listen today. So that's no mean feat, absolutely.
It was so fun. Thank you so much. Have a great day.
Take care, everyone. Thanks for joining. Bye-bye.